Can I check whether I'm audible enough? Okay. So this series is a continuation of our regular series, webinar series, where we engage with seasoned experts in the field to discuss various issues related to Lassa fever, other viral hemorrhagic fevers. And today we are going to be looking at a webinar that is themed Building Ready and Resilient Treatment Centers. We'll be having two presentations. One is a keynote presentation on treatment center preparedness for Ebola virus disease. Then we'll be having an insider experience on treatment center's journey towards Ebola preparedness, where we'll be looking at the experience, lessons, and opportunities. As people join, I think we'll just continue. I can see we have 12 people already on the call. We hope that this number will increase as we continue. So therefore, I'm going to be taking us through our agenda. My name is Dr. Abdulaziz Kuna. I'm from Georgetown University. So we'll be following this agenda to guide us throughout our webinar today. Um, so we'll be having welcome remarks by our esteemed colleagues from CDC, NCDC, um, who we planned and implementing this webinar series together. Then we'll be having brief introduction of the speakers to know who they are and what are they going to share with us based on their experiences and background. Then we'll be having a keynote presentation for about 30 minutes by Dr. John Tunde Aremu. Then we have the case presentation by Dr. Chizara for 25 minutes. We will then have a 10-minute question and answer session where we'll have the opportunity to ask questions, share your experiences, and interact with the presenters. Then we will close the session. So without further ado, I would like to call upon the incident manager for Lassa fever, Dr. Um, Yetunde Abioye. The floor is yours, ma'am.
All right, thank you so much, Dr. Kuna, for that wonderful welcome. It's a great pleasure to be part of this webinar series, and thank you so much for the wonderful collaboration between our team and also your lovely team. So to everyone on the call, thank you so much for joining. Thank you for being part of this series. And if this is your first time as well joining, I'm very sure this will be it will be worth every moment and every second of your time. This series is quite important because especially this particular one, yes, we know that Lassa fever is a VHF, but then especially with what's happening globally and on the continent as well with regards to Ebola preparedness, you all agree with me that this is very timely. So we hope at the end of this, as much as maybe your focus or your experience has been on Lassa fever, majorly, except those that have been part of previous responses and maybe the major outbreak we had in West Africa in 2014, you agree with me that we can all leverage on this particular structures that we have to get ready to act in case we have a suspected or confirmed case of Ebola in the country. So without further ado, I give everyone a very good thumbs up for being part of this and also dedicating time to be part of this. I also want to deeply appreciate our keynote speakers and also presenter from University of Port Harcourt, who will also be sharing experiences they've had, and everyone within the community be able to gain invaluable knowledge and experience and to be able to share what they are also doing within their own practices. So thank you so much, Dr. Kuna, and thank you to everyone that has been planning behind the scenes to ensure that this is success, especially to the IT people as well. with my warm welcome remarks. So thank you so much and over.
Okay, thank you very much, Dr. Etunde, for this very impressive remarks. So next, I'll just be briefly taking us through some basic helpful guide that will help us, go through the session smoothly. So we'd like to inform you that our sessions are very hello, can you hear me? Sorry, I think my network broke a bit. Yeah, so we're recording this session, and so please kindly keep your microphones muted unless you are someone to speak. Then ensure that your device bears your full name so that we can easily recognize you. If you want to raise a question or any remark, please use the raise hand function, and then be mindful of background noise when you are asked to speak. So we'll now be moving on to the discussion proper. But as we go on, please try to interact, use the Q&A box to ask your questions and also share your own thoughts and experiences from your own treatment centers. Let us know what you are doing and what challenges you are facing and what successes you are recording. Thank you very much. So I will now be introducing our keynote speaker in the person of Dr. Tunde John Aremu, who is a seasoned infectious disease and public health specialist with several years of experience. He has led outbreak responses for various diseases, including Lassa. Pillar in Gombe State. He has also worked with several organizations to train health workers in outbreak preparedness and clinical care. He's a founding fellow of the Lassa Fever Clinical Management Fellowship, and he's passionate about strengthening health systems and improving health outcomes. So, ladies and gentlemen, join me to welcome our keynote presenter, in person of Dr. Tunde Aremu, who will be taking us through treatment center preparedness for Lassa fever, for Ebola virus, I beg your pardon. So I will stop sharing my slides at this moment. And Dr. Tunde Aremu, the floor is yours. Thank you very much.
All right, good morning, everybody. Please confirm that you can hear me and you can see my slides.
Yes, Dr. We can see your slide and we can hear you.
All right, thank you, everybody. Good morning, and thank you for joining. Thank you, Dr. Yetunde, for the wonderful work you're doing in NCDC, and Dr. Kuna and your group in Georgetown University. So today I'm going to be talking about treatment center preparedness for Ebola virus disease in Nigeria. And the most important question would be, are we really ready? And if we are, fine. If we are not, there's an opportunity for us to be ready. So I'll look at our preparedness journey from threat to readiness, looking at this roadmap from the threat, the space, the shield, the people, the care, the supply, the watch, the community, the command, and the pledge. It's actually a roadmap. So it's a journey that we all have to go through. It is not promised to be a pleasant journey. It also would not promise that there will not be bumps on the road, but it's a journey that nevertheless is necessary. It's a journey that, despite the fact that you may have difficulties, but if you want to build a resilient system, it's a journey that we must embark in. So follow me through this journey and let's see what we can make of it. So for every preparedness for an outbreak, the most important thing is you must know who your enemy is. What is the bug? And how does it affect or how does it cause a threat to either national health system or the national health outcome of every country? So we're talking about Ebola virus, and we also know that this cannot be a distant threat based on its history and based on what he has done in the past, and it's also now a present danger. The case fatality rates for Ebola virus range between 50 and 60%. It has reached a maximum of 90% at a time. In other words, if you don't have a prepared system, every 10 persons that get in contact with the virus, 9 of them may die. We have had 11 outbreaks right from 1976, when the first one was recorded in DRC. The incubation period is 21 days. It is what we call the silent incubation period. So in other words, from the point at which the virus gets into the body, it may stay in the body for 21 days, replicating, may not show symptoms, and when the symptoms finally appears, it may be too late for the patient, and it's also the time at which the rate of infectivity becomes very, very high. So why must Nigeria act now if you have not acted before? Nigeria shares land borders with a lot of countries: Cameroon, Niger, Benin, and Chad, all adjacent to an endemic zones, especially in West African countries. And beyond that, our population and also our history of constant travels because of trades and because of other stuff that we need to travel up. Lagos and Abuja are global aviation hubs. An infected traveler can arrive within hours of an outbreak anywhere from Africa. Then the 2014 Lagos importation proved this. So it is not an imaginary story. It's something that we have lived before. And Nigeria only had days to prevent what would have been a catastrophe. So let's go back in time and let's look at what really happened on that fateful day, July 20, 2014, when Ebola visited us in Lagos. A single infected traveler from Liberia stepped off a flight at Murtala Mohammed Airport. What followed was Nigeria's greatest modern public health test and most remarkable victory. Day one, the index case, Patrick Sawyer, collapsed at Lagos Airport, was admitted at a highbrow private hospital. Specimen was confirmed at day 3. Contact tracing began day 7. About 894 contacts were eventually listed and followed up for 21 days. By day 21, Port Harcourt had a secondary chain identified. It was contained. Finally, total of 19 cases were diagnosed and we recorded 8 deaths. By day 84, WHO declared Nigeria free of Ebola. I described that as a spectacular success story. But the most important question we must ask ourselves, and that many of us asked ourselves that time, was that, were we lucky or was our system robust enough to contain it? With whatever the case it was then, I think it triggered something in the country that made us believe more that preparedness is key. And I know after then, many EOCs were opened in different parts of the countries, and that singular act assisted us more to cope with the COVID pandemic better. So we also need to appreciate the space. You cannot fight Ebola in an ordinary hospital. That has to be very, very clear. The physical environment is the first line of containment, however. So we have a green zone where there's a low risk. We have a yellow zone where it's a moderate risk, and more importantly, the red zone, where confirmed cases are, where we normally site our treatment unit or centers, holding areas, and more importantly, waste management. There must be a one-way patient flow. No crossover is permitted. Negative pressure rooms, dedicated hygienes, and other IPC measures are not optional. Double door entry points and on-site incinerator. Unlike Lassa fever that we deal with presently, Ebola is a non-forgiving virus. It doesn't give us that luxury of you get infected and you may be spared of the consequences of the outcome. So in other words, if you prepare 60% for Lassa fever, you must prepare 80 to 90% for Ebola. Then we need to look at the shield, what protects us, which is the infection prevention and control. Most healthcare workers who die of Ebola are killed by lapse in protocol and not bad luck. Lapse in protocol usually occurs because people are either not aware or probably there's a distinct difference between knowledge, the attitude, and of course the practice of IPC. So we all know what standard precaution is. Hand hygiene, safe injection, respiratory etiquette at all times, in all areas, and not just in EVD zones. Remember that incubation period. Many patients may come to the clinic with just fever. So it means that our standard precautions must be at all times, in all areas, for every patient. And we must also appreciate the rate or the way in which a particular bug is spread. That would determine the emphasis we will pay on some certain personal protective equipment. For Ebola virus, it's usually contacts, and for all suspected confirmed cases, PPE is mandatory before entering that yellow or red area from the green zone. Then PPE must be supervised. You can never be a superstar in PPE donning and doffing. You must have somebody overlooking you and assisting you to either don or doff. Many infections are begotten either through improper donning or improper doffing. Then environmental decontamination is very, very key. The virus can stay in the environment for a significant period of time. Sharp and waste safety must be properly disposed. And healthcare monitoring. Twice daily temperature check for all staffs that work in these treatment centers. Then for those that have symptoms, 21 days monitoring. Post any exposure, sometimes you may need to give a sick staff to stay at home. So by practice of PPE zone, the right PPE is important at the right place, at the right time, and at every single time. For the green zone, there are barest minimum of PPE that must be used: scrubs or uniform, surgical masks, gloves where indicated, and hand hygiene. When you get to the yellow zone, it becomes a little bit layered. More scrub and gown, double gloves, face shields, boots covers, and apron. At the red zone, when you have confirmed cases, impermeable full overall, N95, face shield, triple gloves, boot covers and rubber boots, waterproof apron, and full head care cover. No staff member should remove PPE alone, regardless of what you think your expertise is. And you must also remember that chlorine spray always becomes handy. There should be no exception. There should not be exception of I've been in this game for 20, 50 years. Everybody must follow these principles. So the workforce preparedness. No building defeats Ebola. Only trained and fearless people do. So trained and fearless may not necessarily go together. You may be trained and not fearless, and you may be fearless and not trained. First, you have to be trained before you become fearless. Knowledge actually makes people to be bold. For clinicians and nurses, case management, triage, IV access, clinical monitoring, and bedside care. It is what they have to be prepared for. How do you manage these cases? How do you carry out the triage? How do you observe standard precaution when you are providing clinical services? Then IPC officers must conduct daily IPC audits, PPE supervision, decontamination oversight, and healthcare worker surveillance. Laboratory side, BSL-3 trained, specimen packaging, RT-PCR, cold chain management, and psychosocial support. This is meant for both the patient relative, and definitely the healthcare worker. Many a times we do not consider psychosocial support for people that have stayed in those treatment centers for days. They also need it. Safe burial teams and security and logistics, which will control access, supply chain, ambulance crew, and waste handlers. And there must be standards to these trainings. Many a times we do training just based on, we think we have done training long time ago. Let's just schedule another one. There must be standards to this. There must be minimum of 3-day EVD training before any deployment. So regardless of the type of training you have had before you are deployed to that treatment center, there must be either a refresher or a new training that must be at least a minimum of 3 days. There must be quarterly simulated outbreak drills. Many a times you need to do this more, depending on how many staff come in and go. Don't do a simulated drill at the beginning of a quarter. And by the time you are coming to deploy people, they are completely new people. So all of those things must be checked. Assess PPE donning and doffing competency. Refresher training every 6 months. Post-outbreak psychosocial debriefing is mandatory. All Ebola treatment center staff certified and listed in the registry. So for every treatment center, you must have a book log that will outline everybody that have been trained, in what they have been trained in, and when they were trained. And it has to be standardized, NCDC, WHO standard training. So we all know that there is no cure, but with the right care, patients can survive. We start with the triage, apply case definition, then risk stratify at entry. Isolate when meets the case definition, collect samples, confirm case, treat Many a times is supportive. The more aggressive you are with the supportive treatment, the higher the chances of the patient surviving. Then the outcome, the patient may recover, and after recovery, you need to follow up after 21 days. Sometimes, sadly, some will die, and there must be safe and dignified burial. Remember that inside the safe and dignified burial, what is more important is overall cover of IPC. So what saved lives at the bedside? As I said, the supportive treatment, dehydration kills more than the virus itself. For Ebola virus, some therapeutic agents have been tried, monoclonal antibodies. That is, if they are available and if they are funded. Pain control, comfort care, dignity, psychological support for every patient. Treat concurrent infection, meticulous sharp safety, and daily records. And you have an NCDC line list updated each day for all active Ebola treatment center patients. Many a times we get so overwhelmed and we forget the importance of the data that are generated. The line list is very key because within that line list, another person with the disease may just be sitting and waiting for all of us. So you cannot improve an outbreak. You cannot improvise during an outbreak. Early item must be counted, stored, and ready before the case is reported. So while we are preparing now, we should be looking closely at our logistics and stockpile for readiness. PPE stockpile is very important. We must have at least a minimum of 3 months stock. Pharmaceuticals, especially for supportive care, lab and diagnostics, triple package specimen, which lab the sample will be sent to. There must be a functional network of lab. Every treatment center must know which lab to send the samples to. Then decontamination and all the ingredients needed for this, communication, whatever your treatment center will make for an efficient communication should be in place. Supply chain golden rules, pre-position a designated treatment center. NCDC manages national buffer, state EOC stockpile, WHMSF as such backup, never single source procurement, FIFO rotation, and track expiry dates. So in other words, just like many parts of this preparedness, for logistics, coordination, collaboration is key. What will it benefit a country that has prepared and does not have a stockpile to either defend itself or to also treat the patients? So the watch, the surveillance, lab, and diagnostics, we cannot respond to what we cannot see. So we must first identify the patients. And that's why the case definition is quite important. We must all know this. We must have it as SOPs in every treatment center. We must have it as SOP at our outpatient department so that every healthcare worker that comes in contact with every patient should be able to identify a suspected case. Then there must be an immediate notification. There's a NCDC hotline for this. And I also know that for many states that have an operational EOC, there's also an immediate notification through the DSNOs. Then contact tracing must start immediately. And for those that have been listed, daily follow-up for 21 days to look for any symptom that may suggest the presence of a case. Then event-based surveillance, community informants, media scanning, and animal dials are monitored as early signals before a human case is confirmed. These are the Nigerian lab network from the referral lab to the Lead lab to the Redeemers lab, WUAFRO lab, and of course, select state public health labs. I know that before most state labs can become functional, they must have accreditations and they must be certified by NCDC. Community engagement and RISCOM. In West Africa in 2014, communities that resisted lost more lives. Communities that trusted saved them. So we must build trust before the outbreak. This is the time to build trust with our communities. Engage community leaders, traditional rulers, religious figures, and women group now before a case appears. Counter misinformation fast, rapid response to rumors, prepare and discuss safe and dignified burial, work with families, not against them. Cultural respect during burial is critical. Coercion drives transmissions on the ground. So let's don't go as those superhuman beings, healthcare workers, that just walk into a community with our full PPE and want to coerce people. What that normally does is that even people that have the symptoms, they will never come out. So we must build those trust and we must make sure we don't coerce people. Explain, don't command. Community must understand why isolation save lives, why people must be buried that way, and why people must stay in the isolation for a certain time period. What communities need to hear: Ebola is real, early care save lives, do not touch the body of someone who died of Ebola, report fever and travel history immediately. Ebola does not spread through air or water. Health workers are here to help your family. For most of us that are on this call, these messages look very trivial, very simple. It always seems that almost everybody should know it. But the communities don't understand the grammar and the jargons we speak. So we must explain to them in a way they will understand. Don't send somebody that cannot speak Hausa to the corner to start explaining all of this. We may be misinforming them. So the command, which I also call the coordination, this is the part that is dear to my heart. And I feel that for every outbreak, preparedness or readiness, if you don't have a solid command and coordination network, you're actually planning to fail. In a crisis, chaos kills. Clear command structure saves. So for many outbreaks, an incident management system is usually activated. There's an incident manager, either at the national EOC or the state EOC. Then you have the operations, where you have all the technical pillars from case management to IPC to RCCE and all. And you also have the planning, you have the logistics, you have the finance and admin chief. These pillars or these drop downs are not exhaustive. It depends on the personnel you have, the technical know-how, and what fits your local context. The most important thing is that we must know who do what. We must know where the command comes from, where the communication comes from, where the information comes from. There must be a top-down and down-up information flow. EOC readiness, not negotiables. By now, many states should already have an IAP in the EOCs in preparation for this outbreak. So we must activate EOC within 24 hours of confirmed EAC, NCDC EOC on standby from day one. Every role as a deputy, no single person bottleneck in any section during active response. Daily situation reports is important. Mutual aid agreement with neighboring states, resource sharing, protocols pre-signed. This should also be applying to every partner that is involved in supporting the outbreak. So readiness is not a feeling, it is a measurable standard. Infrastructure and zoning, treatment centers within 3-zone layout operational, physical inspection checklists, and should be quarterly. Let's remind ourselves that majority of the treatment center we have on ground now, either a state have one treatment center that takes care of one particular outbreak per time. We are still dealing with Lassa fever in some states. We will not be able to use the same treatment center for different outbreaks, especially with Ebola. Though there are few treatment centers that have compartments that can manage different outbreaks, but the manpower must also be considered. IPC compliance, it must be assessed by structured observation. This should be done monthly. PPE availability, greater than 3 months stocks on hand. Inventory counts monthly. Staff training, 100% of everybody working in the ETC must be certified. Training records review. This can be biannually or whenever it is needed. Drills and simulations, more than 2 full drills per year. Drill reports plus after action review. This all should be biannually. Lab turnaround, lab log books, alert notification to NCDC less than 24 hours, contact tracing greater than 80% contact trace daily, contact tracing database per outbreak. So this will look like another guide in a binder. Almost every treatment center, every organization have this on the shelf. We must move away from putting these things on the shelf and let it be a really live and working document. We should be assessing this every time, that even before we record the first case. So what worked in 2014 and where the gaps remain today? What worked in 2014 was that there was a rapid contact tracing. There was political will. There was international partnership from WHO to CDC to MSF. There was a pre-existing UC, which was built around polio, but was further expanded before COVID came. Community trusts from prior engagements and daily transparent media briefings. For those that were around that time, you realize that the briefing and the sharing of information from NCDC sometimes can be 2-3 times a day. Those were some of the reasons why it worked at that time. So what are the gaps that we still have now that must be addressed? Obviously, we have insufficient Ebola treatment centers outside Lagos and Abuja. We must try to designate one treatment center at least per geopolitical zone. PPE stockpile has been depleted since post-COVID. Let's rebuild the buffer. Limited trained EVD staff in rural states. There must be a training. Community distrust from COVID hesitancy. We must intensify health literacy campaign now. Then limited lab capacity outside federal level. We must start thinking of upgrading state labs for VH screening. So what will be the call to action? The next Ebola case in Nigeria is not a question of if, but when. What we do today determines how many people survive that day. So governments must make available fund and certify at least one ETC. It is nice to know that government has released 10 billion. Health leaders mandate annual EVD training. Clinicians commit to IPC compliance every day. Committees trust the health system. And all of us invest in preparedness as seriously as we invest in response. So I'll just quickly go through what are we really preparing for now. Is it Ebola or is it the Bundibugyo virus? That obviously is the virus that is causing an outbreak in both DRC and Uganda. Are there differences? Are there similarities? What can we learn from the differences? So there are viruses of two cousins, one genus, a clinical, epidemiological, and therapeutic comparison. So remember that all the viruses under the family Villoviridae are 5. There is the Ebola virus that is common to us, which is the Zaire variant. It has accounted for most of the outbreaks. Then we have the Sudan virus, which is a human disease. And presently, we have the Budumbujio outbreak. This is the outbreak that we have in DRC. And this type forest, it is rare. And there is the Reston or Bombali virus, which is not a human disease. So Ebola disease is an umbrella for illness caused by the genus Ebola-virus. The virus usually mean by Ebola is Zaire Ebola virus. Bundibugyo virus is sibling species in the same genus, closely related and not separate. So species genome differs by greater than 30%. BDB is genetically closest to Thai forest virus and distantly related to the Ebola virus that we all know, the Zaire variant. So it is a true cousin with its own surface glycoprotein. When you have two different viruses having different covering of glycoprotein, that means therapy will change and vaccines will also change. This is a very head-to-head comparison of both of them. I'll just look at the ones that really concerns us as we prepare. The typical fatality for the Ebola virus of the Zaire variant is about 55 to 90%, while for the Bundibugyo virus is about 25 to 50%. Because Ebola virus of the Zaire strain has been with us since 1976, there have been attempts on approved treatments, Imazeb and Ebanga, and there's also an approved vaccine. Bundibugyo virus, this is the 3rd outbreak, so there is no approved treatment. There is no approved vaccine. So that is a major, major gap. So the bottom line, clinically and biologically, very similar. Decisive gaps are in fatality, approved treatments, and approved vaccines. So again, this is just to show that both are of the same family, same origin, same biosafety class, but there's a subtle difference. Lab studies suggest BDBV replicates more slowly than ABOV, one hypothesis that points to the fact that it is generally lower in lethality. So the Ebola virus, as I said, we have been dealing with the outbreak since 1976. It's behind the largest epidemics, including West Africa, major and DRC outbreak in 2018-2020, which drove the vaccine and drug approvals. It's recurrent across Central and West Africa. However, Bundibugyo virus is first seen in 2007 in a district in Uganda called Bundibugyo. Second outbreak was in DR Congo in 2012. Now we are facing only the 3rd ever BDB outbreak in 2026, DRC and Uganda. So it's a rare species, far fewer historical events than Zaire. What I know for sure with many viruses is that by the end of this particular outbreak, we will learn more from this virus and we also be able to prepare for it better. Shared driver. Both outbreaks are amplified in healthcare settings with weak infection control, especially during unsafe burials. So from birth to people is the same for all of them. All of them, both of them, is not an airborne, it's by body contact. And clinically indistinguishable at the bedside, For Ebola virus, 81% of them present with non-bloody diarrhea, 81% have severe headache, and they have asthenia, general weakness. So in the setting of this our preparedness, when somebody presents with non-bloody diarrhea, severe headache, and general weakness, and we are also in the season of cholera, let's keep our thinking cap on and let's keep our alert system on. So they can present two ways, either the early dry phase, where there is no vomiting, no diarrhea, or the wet phase. However, when the patient gets to the wet phase, it means the viral replication is at a very high level, and it's at this stage in which people get really infected, and it's at this stage that the disease or the virus can easily be transmitted. So, investigation and diagnostics. So I'll just go through. They are same in some way, the way it is diagnosed, but the diagnostic pitfall, species-specific assays, a Zaire-specific PCR will not reliably detect the virus. When BDV first emerged in 2007, sample tested negative on highly sensitive Zaire and Sudan-specific PCR assays. The new species was only found using a broadly reactive antigen assay and pyrosequencing. Outbreak therefore need pan-filovirus and broadly reactive assays on BDV, specific primers, and rapid field diagnosis remain a major operational challenge. So while we prepare for that first case, let's remember that in form of diagnosis, there's a subtle difference between the kits that can diagnose the Zaire strain of Ebola and that of the Ebola virus. That should be taken into consideration so that our lab colleagues should be aware of this. So again, as I said, there's no targeted drugs for Bunjibaro, but we still have some experimental ones for Ebola. It's not readily available, but for Bunjibaro virus, there's no approved therapy. So both of them are lethal, but the Zaire virus is more lethal. Vaccines, as I said, there's no vaccine yet for the virus, and that is understandable. As I said, this is the third outbreak ever, so I'm very sure by now people have started thinking about the next plan, but there's an encouraging plotline from January 2026. People have started thinking about multivalent virus vaccine that will target all the strains in the Ebola family. So where they differ, Ebola virus is common and recurrent. As at now, as we know, BDV is rare because this is the third ever outbreak. Ebola virus is more lethal. It has more approved drugs, has licensed vaccines, but the virus have a different glycoprotein, so there is no automatic cross immunity. In other words, when you are infected with Ebola virus, you will not necessarily have immunity against the new virus. So what are the key takeaways? Same family, manage identically, test is more deliberate, lower fatalities for virus, but in both of them, early supportive care saves lives. For both virus, getting patient into care early is the single biggest level on survival. So Ebola will not ask if we are ready. It will reveal whether we are. So for every outbreak that we have, it will not ask us whether we are ready. The way we handle it is the test that will reveal whether we were actually ready. Preparedness is the silent work we do before the crisis. Response is merely the evidence of whether we were honest with ourselves. And this is very key. While we attend all the webinar, while we attend all the meetings, response will show the evidence whether we're honest with ourselves and we're ticking all the checklists. Treatment center is only as prepared as the system behind it, because in an outbreak, readiness is not declared, it is demonstrated. I want to thank everybody that have been in the forefront fighting for every form of outbreaks, not sleeping, putting themselves in the front line, and ensuring that we are all safe. Thank you for the wonderful job you're doing. I also want to thank you for listening to me while I go through this presentation. Preparedness is not an option. It's our responsibility. Thank you very much for your attention. Over to you, Kuna.
Thank you very much, Dr. John Tunde Aremu. This is really a very high impact presentation, I would say. Inspiring, educational, motivating, and actually calling all of us to action. Thank you very much for the knowledge shared and the call to action. I will quickly now move on to the next speaker. I will encourage you to please start sending in your questions so that we can take note of them, and I'm sure Dr. Tunde Aremo will be here with us for a bit to answer them. But I will quickly move on to introduce our second presenter, which is Dr. Chizara Onigala, who is a clinician scientist who has over a decade of experience across internal medicine, infectious diseases, and global health. He's currently the coordinator of HIV care and treatment program and the case management expert for high consequence infectious diseases at University of Port Harcourt Teaching Hospital. Besides his clinical and research activities, he's also an editor with Infectious and Emerging Diseases Journal of the Public Health in Africa. So ladies and gentlemen, kindly welcome our next presenter, who's going to take us through the treatment center's journey towards Ebola virus disease preparedness. Thank you very much, and I will stop sharing my screen now. Dr. Chizara, over to you.
Good morning, colleagues. Thank you, Dr. Kuna, for having me. Let me share my screen. Good morning again, colleagues, for having me to make this presentation. I want to sincerely appreciate Global Georgetown University, Nigeria, and the Nigerian Center for Disease Control for finding University of Port Harcourt Teaching Hospital Treatment Center worthy to share our experience towards Ebola preparedness. I also want to appreciate Dr. Aremu for his very thoughtful and brilliant presentation. So as a background, I want to start by saying what we already know. Ebola virus disease remains a high consequence pathogen with epidemic potential. And we know already that the continent had witnessed large-scale outbreaks, primarily in the Central and East Africa, Nevertheless, we had the largest outbreak within our own region of West Africa, and that the recurrent outbreaks we're having in the continent continue to underscore persistent vulnerabilities, both in the socioeconomic burden and also resilience in our healthcare system. And that, continues to highlight the need for us to maintain continuous readiness and not episodic or reactive responses. So from a global and national context, we already know that there is an ongoing Ebola Virus Disease outbreak in the DRC and Uganda. And I know that in line with the international health regulation, both countries of the DRC and Uganda notified the WHO on May 15th of a cluster of viral hemorrhagic fever-related deaths in, I think, Ebola virus disease. And then on May 17th, the WHO, considering the international health regulation recommendations, declared public health, declared AVD, a public health emergency of international concern. Similar to what happened with Mpox in 2024, the Africa CDC, which now is beginning to establish its regional responsibility as a continental health security champion for the continent, also declared it a public health emergency of continental security following the recommendation by the emergency committee group. Now, back to our country. Nigeria Center for Disease Control proactively issued a national health advisory on May 17th, calling for vigilance and responsive operational readiness across all tiers of healthcare settings, which they have to send another public health, a more detailed public health advisory on May 28th of 2026. Why does facility level preparedness matter? From the previous presentation done by very esteemed speaker, Dr. Remu, we have seen that delayed recognition, which is usually almost the case, with the ongoing outbreak, particularly in the DRC, leads to nosocomial amplification, and that high case fatalities are often common with AVD without optimized supportive care. The WHO always talk about early optimized supportive care as one of the foundations to reducing the case fatality rate. And then, of course, we know that from the epidemiology of Ebola virus disease, the family members and the healthcare workers are two populations that are often at risk. The family members often could become dead-end hosts. However, the healthcare workers can serve as major outbreak amplifiers. So what does preparedness entail? In a nutshell, preparedness entails early clinical detection, isolation, infection prevention and control, and clinical readiness. And all of these underscore the need why facilities, particularly at high-risk facilities such as the states that have been mentioned in the advisory by the Nigeria Center for Disease Control, which includes River State. And of course, we saw from the previous presentation and from our knowledge about the 2014 West African Ebola outbreak that the next day we had the case in Rivers because of our borders, airports, land, and sea. So just to talk a bit about our treatment center and also highlight our modest experiences which we've gained over the years. Treatment center started as a very small room or two, 3 rooms. And during the COVID-19 outbreak, with what happened in most other treatment centers, we had Nigeria, had to rapidly respond by setting up rapid isolation centers in line with the Federal Ministry of Health recommendation. So we went into a 20-bedded treatment center, which was not really purpose-built, but was enough to allow us to provide care to COVID patients. Now we have moved, in the post-COVID era through World Bank Health Systems, strengthening support to a dedicated and a purpose-built infectious disease treatment center designed for isolation and management of high consequence infectious disease. So just to provide a bit of an overview, which is what you see in typical well-designed treatment centers. Ours is that of a 40-bed capacity, structured for surge response, and we have 4 suspect rooms because you don't want to keep the suspect patients within a particular ward because of cross-infection and the fact that some of them discharge them home. Then our confirmed ward is structured for male and female, differently 10 beds each. And then we'll have a pediatric section, 2-bed intensive care units, a hemodialysis unit, a mini theater for minor procedures, a dedicated mini laboratory section, doffing and donning areas, body holding area for the temporary storage of corpse before mortuary transfer. We also have reception, nursing area, and a conference hall. So to also add a bit of the structures that we obviously need to provide care for high consequence infectious diseases in an ideal treatment center is the fact that our treatment center is also centrally piped. We have a central pipe oxygen connected to the hospital's oxygen plant. UPTH is also lucky to have the oxygen plant for the state. And also to add that the World Bank support for the treatment center was one-page geopolitical zone. And the University of Port Harcourt Teaching Hospital was actually lucky to have this World Bank support come our way in terms of setting up a treatment center. We also have a dedicated solar-powered electricity with a generator backup, which is built following the COVID-19 pandemic, where we discovered that many of the resource-poor settings where COVID played, very deeply, had constraints with oxygen security. And also all of this is aimed to deliver high acuity clinical care, which WHO often terms as, optimizing supportive care. All our clinical and case management care is rooted in the robust IPC infrastructure. In December 2025, the hospital, in its thoughtfulness, created a unique center for infection prevention and control and antimicrobial stewardship, which is to serve the hospital in collaboration with the outbreak committee and the treatment center to provide staff training, protocol standardization, outbreak response coordination, and overall serve as the critical backbone. And this serves as the critical backbone of our EVD preparedness strategy. We also boast of a multidisciplinary workforce, which includes the clinical team, including the pediatrics and internal medicine, the laboratory teams, community medicine team, like the previous speaker has stated. And as I always like to emphasize, the community engagement, particularly during inter-epidemic periods, very critical to what you do during response, because the nurses and the assistants are very critical in providing frontline care. You cannot overemphasize the role of the hygiene in making sure that protocols in terms of donning and doffing is maintained. Psychosocial support appears to be very key in providing care for patients that undergo isolation, sometimes prolonged isolation. In one of our cases, we had a patient, who broke down the glass of our previous treatment center, that she will not continue to stay on isolation. And I remember that we had our psychosocial team come see her that night and provide some level of care, which helped us to manage her better. All outbreak treatment centers should have a security outpost because of conflicts and because of all the other tensions that can happen during outbreaks, during such periods in treatment center. Logistics, very, very critical. And I remember last week, I was just coming into the hospital and I saw the ambulance driver and I asked him, "Are you ready?" He said, "Okay," highlighted some of the challenges and all of that. But of course, you need to know that you need to continue to keep them, ready and mentally prepared for what is to come. So to share our modest experiences in delivering high consequence infectious diseases across the country, it's important for us to know that we are actively involved in the mpox response since the 2017 re-emergence, contributing data, deepening the understanding of the mpox literature globally. And we also played major roles during the 2022-2023 global outbreak, which also helped to strengthen and consolidate some of the information and the knowledge which we have today in the global mpox landscape. Some of these also had been further highlighted by the upsurge of mpox outbreak in the continent during the 2024-2025 outbreak. And as a matter of humility and modesty, our center was actually recognized by the Nigerian Center for Disease Control as a national reference center for mpox care during the public health advisory by the DG during the 2024 outbreak of Mpox. In 2025, we've managed the highest number of Mpox cases in the country and reported 4 out of the 6 days at the country. And this has offered us some critical and crucial insights to knowing some of the challenges that Mpox cases tend to have, when they are isolated and when they are under care. We've also supported research at national, state, regional, and international levels, often helping to better know more about this disease. During the COVID-19 outbreak, we were not left out. If we look at the total disease burden of COVID-19 in country, Lagos may have come first, but Rivers State was somewhere there at the upper numbers of states that have the burden of COVID-19. And we had to manage large volumes of severe critical COVID-19 cases across the various epidemic waves. And importantly, we reported the first MIC in Nigeria and probably in sub-Saharan Africa. And this gave us a lot of recognition, both at the national and international level. COVID-19 experience helped us a whole lot as a treatment center, which is not a typical traditional Lassa fever treatment center, to build capacity in critical care, in oxygen care, and in multi-system disease management. And also, we were also recognized to support international research collaborations, including WHO Solidarity Plus trials, where 3 medications were tested as part of COVID therapeutics. Our experience with Lassa is that of sporadic cases over the years. But in 2024, we reported 7 cases, confirmed cases of Lassa in Rivers, and our treatment center was privileged to manage 6 out of those 7. And this is adjudged to be the largest outbreak for the state in terms of Lassa. And importantly is to highlight one of the cases of the Lassa patient, which underwent 7 sessions of hemodialysis, improved clinically, and was discharged home. I remember that when we had this case, I had to notify the incident manager of the Nigerian Center for Disease Control, Dr. Yetunde, who now linked me up with Dr. Winifred. And Winifred was asking, do you guys manage cases of Lassa in Rivers? I thought people send the case to Irua when they have Lassa, and I said, well, okay, we're able to, we've managed more than this. If you look at the reports at the NCDC, you'll see that already at the time, Rivers already had about 7 cases, and the 7th case is the one I'm reporting to you about. So in all of that, we're able to demonstrate ability to manage to provide organ support and complex infectious disease care. We also have a different treatment center, just like the previous speaker had mentioned. So you need to begin to ask yourself, can one treatment center serve all of the emerging infectious disease outbreaks at the same time? So those are the questions that people that desire to set up treatment centers should begin to ask themselves. But programmatically, the University of Port Harcourt Teaching Hospital hosts the South Regional Drug Resistant TB Treatment Center. And also we have the Geopolitical Zone Molecular Laboratory to play along with that. This has also helped us over the past 10 years to build expertise in long-term infectious disease management and also provide some level of infection control across all the transmission risks, importantly, airborne diseases. We have also supported the NTBLCP in the WHO-funded landmark study where we tested modified all-oral regimen against the then injectable. And this has provided some of the insights to which why we are using modified oral at short course in providing care for DRTB. Our facility members have also been undergoing some level of personal capacity development, which you need in an emerging and rapidly evolving landscape of outbreak disease response and management. Our facility nurses have done some levels of rigorous training in IPC, and over the years have gained progressive experience to providing care to severe and critical high consequence infectious diseases. We've also had some members that have gone for fellowship in genomics, bioinformatics, and data analysis. And this has helped us not just at the treatment center level, but at the regional level, at the global level, at the national level, to be able to interpret data at the genomic level, at the bioinformatic level. This helps you, to gain competencies, to be able to know what is happening and what is to come. We've also had some of our members to go that had gone through some levels of observerships at the national Public Health Institute equivalent, which is the UK Health Security Agency, where we've gained some level of experience in addressing imported febrile infections and exotic pathogens. I was privileged, and some of other members of our facility had attended the Lassa Fever Clinical Management Fellowship, where we gained a whole lot of experience in Lassa Fever Clinical Management and all that come with our other viral hemorrhagic fever like syndrome approach, which may not necessarily be Lassa fever. We also had some of our colleagues in the Institute of Tropical Medicine in Antwerp, Belgium, gaining experience. We're also a member of the network of clinicians for WHO clinical management in the global and regional level. If my French is very good, I probably will be in the DRC by now. And then I also want to finally add that my role as a section editor for the Emerging and Infectious Disease section of the Journal of Public Health in Africa, which is the Journal of Africa CDC, has given me some level of outlook into the contextualities of what communities, states, provinces, regions, health zones, and countries are reporting in terms of outbreak across the continent. Because I have to sometimes go through some of these publications and see whether some of them meet the requirements required to direct science and advanced scientific discourse across outbreak responses in the continent. And then just to share a bit of our global and national engagement and guideline development, some of our members have also participated at WHO global level initiatives on mpox clinical management and infection prevention and control. We've also supported NCDC in revising the mpox case management guideline. During the 2024 global upsurge of mpox within the continent, we also supported policy framework and operational deployment of mpox vaccines. We presented some of our initiatives because research must be embedded in outbreak response. Research must be embedded in case management. Research and the future outbreaks, which will definitely come. So we'll share some of our experiences, both as oral and poster presentations at various conferences which we proceeded. And our former chairman medical advisory committee and our boss, he also supported COVID-19 pandemic as an expert in Malawi, also highlighting the strength of the treatment center. So all of these experiences which we have gained has helped us as a treatment center and as an institution to transition to the EVD preparedness. So safe to say that on the 1st of January, the hospital had a new management and chief medical director who, in his own initiative, proactively prioritized the setting up of IPC outbreak committee the next month as one of the standing committees of the hospital. And in all of this, this has provided the committee with the support, to carry out its roles. And one of the things that the committee did was to do an internal risk assessment of the facility readiness, because we know that early preparedness is always an advantage. You see, this is one of the pictures where the committee was meeting and sharing insights to what, as a facility, where are we, what are our gaps, and what do we need to do to get to the next level. So some of the preparedness interventions which we did, which I will be highlighting, include we had to, when we did a system stressing, we found some gaps, including at the pediatric end, and we had to discuss holding areas and the need to have holding areas embedded in the emergency department. We're also talking about establishment of triage points at critical service points of the hospital, which includes but not limited to the adult emergency, pediatric, family medicine. And we also have a planned simulation drills, particularly for our frontline healthcare workers in collaboration with the hospital simulation center. This is one of the pictures where we were doing a facility-wide training, and you could see the IPC focal person doing more of the IPC training, and we had a very large turnout, over 300 participants, including all walks of cadre, non-clinical and clinical staff of the hospital. Also, we also went further to do IPC strengthening. Already during the entire outbreak period, And the IPC committee had been doing a lot of consensitization trainings, and also we participated very actively in the World Hand Hygiene Day, which also provided the hospital and the staff the opportunity to learn more about the critical importance of hand hygiene. But in the context of the EVD preparedness, we had to review and talk about how we could stockpile our PPEs. Just like the previous speaker had mentioned, you are not going to do improvises with Ebola virus disease. It is an unforgiving disease if you don't take the necessary measures. And that also helped us to also look at rehabilitating our hand hygiene infrastructure, and also the plan to install more hand wash stations at critical points. So general training, which we also did, which also would have helped our clinical and non-clinical staff, include the hospital-wide capacity training, which I talked about earlier, where we trained particularly on case definitions and early clinical recognition, donning and doffing procedures, WHO 5 moments of hand hygiene, and the techniques for hand hygiene practice, chlorine preparations, waste segregations, and then the state of the preparedness of our incinerator. And this is a picture where we could see our frontline health nurses, particularly those that have training in IPC, and in practical terms, demonstrating how hand hygiene should be done. In terms of laboratory preparedness, we are not left out, because we know that without laboratory detection, without pathogen isolation, you are flying blind in outbreak response. So we had to do some level of training on safe sample handling in terms of end-to-end pathways, and then also predefined sample transport pathways, both internally and externally, because the state does not have a designated molecular laboratory center for EVD detection. So we needed to look at our transport pathways internally and externally. Of course, we also looked at our laboratory pathways for our routine tests for suspected cases. How do we do our biochemicals? How do we do our hematologicals? How do we do our basic point of care tests? All in all, ensuring safety of the laboratory staff. The reference laboratory, we have had a false alert or a false case of EVD where we send samples to Abuja, National Reference Laboratory in Abuja. So that also afforded us the opportunity to test run how rapidly we can be able to take samples to Abuja. I'm very delighted to talk about our upcoming Global Fund supported integrated molecular laboratory, which the picture is clearly shown there. And this Global Health Fund supported integrated laboratory is to integrate the traditional endemic diseases, the HIV, TB, and malaria. But in terms of, and in the context of the integration, molecular laboratory workflows are often, we also involve our epidemic infectious diseases such as Lassa and others. So what are our identified gaps and needs from all our preparedness and all the drills that we have done? Infrastructure gaps exist, both in the triage areas and in the treatment center. A single case of EVD is a stressor. Like the previous presenter has said, preparedness, you may not want to be honest to yourself, but the response will show you whether you were honest with yourself during the preparedness. And like I always tell my clinical team, that the EVD management is requires a high acuity clinical care. It's not the typical care which you deliver with Mpox or Lassa or COVID. In fact, I had to give somebody an example, and I told the person that, do you remember the patient that would dialyze 7 times and all the care that we provided to that man to get him up and running? Double that care by 2. That is what one case of EVD will take from you in terms of the protocol design, in terms of the rapid response, in terms of oftentimes you're donning and doffing and the risk involved with donning and doffing at often and several time points during the day. We also realize that we have limited such capacity to respond to this level of care, which is required if an IVD comes our way. Of course, we know that supply chain vulnerability and importance of sustained supply for PPE and consumables cannot be overemphasized. You need this in abundant numbers, because you don't want to improvise for high lethality prone outbreak like EVD. And of course, we need to continuously train our frontline healthcare workers and also boost their psychological morale and preparedness for what is to come. So in all of this, what are the lessons that we have learned as a facility? We've learned that preparedness must be proactive and continuous. It must not be reactive, as it is what is often part of the vulnerabilities and the resilience of our healthcare system test when we have EVD or other forms of high consequence infectious disease threat outbreaks across the continent. Early recognition and laboratory detection embedded within a robust IPC framework is foundational to outbreak control. Experience from prior outbreaks may be invaluable, help to build competence, build morale, and know how some of these things will come. Multidisciplinary collaboration is key. One person cannot do this alone. In fact, it's often advised that you shouldn't go into the treatment center, into the ward to see a patient without a body. Simulation exercises could help, improve real-world experience and real-world response. So it's often advised that treatment centers begin to prime themselves of, how when this case presents, what do I do? Who should I call? And all of that. And just to add that, last week, Sunday, we had a false case of EVD, a patient that came in from Uganda, that we were called, and then we later realized that the patient, which was sick and was on a chartered flight, was coming from Qatar and had to stop the flight had to stop in Uganda for refueling. Right? But that opportunity also afforded us an opportunity to test and see how ready we are in terms of if a case comes, to our state and to our institution, how ready we are, what are we able to do. So what are the opportunities that we are looking to dig into, to capture into, to key into? We are looking towards, supporting national, supporting. We're also looking at strengthening our research capacity during outbreaks, because we know the importance of research capacity during outbreaks. We're also looking at integrating with national and global response networks. Some of these have been done and some are also ongoing. We're also, modestly looking at perhaps it could be a model, for training of outbreak response in the region, in the geopolitical zone, and also in other non-traditional Lassa fever outbreak states. So in conclusion, University of Port Harcourt Teaching Hospital have demonstrated how experience could translate into preparedness. And we have found that Ebola readiness requires 3 key factors: 1, infrastructure; 2, workforce; and 3, system coordination. Sustained investment is critical, especially during inter-epidemic periods, as preparedness today prevents a crisis tomorrow. I want to thank all the participants of this webinar and also Georgetown University for having me. Thank you.
Thank you very much, Dr. Chezara, for this interesting experience and knowledge sharing presentation. We have seen what University of Teaching Hospital Port Harcourt has done and has been doing, and how that is translating to their preparedness for future hemorrhagic fevers. I think this is a good time to move quickly to question and answers. I have just one question at the moment for Dr. Jonathan Aremu. I hope he's still around. I will just quickly read out the question. Unfortunately, I don't know who was asking this question. It's an anonymous participant, perhaps a scientific officer. And he's asking, what is the role of a scientific officer in curbing the epidemic, such as Ebola and Lassa fever? And what can an average rural dweller do during a major outbreak? Dr. Aremu, are you close by? Okay, Dr. Chizaram, do you want to respond to that? Perhaps Dr. Aremu, he told me he has some engagements and he will really be
can you read the question again?
Yeah, so he's asking, what is the role of a scientific officer in curbing an epidemic such as Ebola and Lassa fever? Then two, what can an average rural dweller do during a major outbreak?
So thank you to the person that's asked the question for your very important question. So a scientific officer is a scientist in the real sense, and every scientist have a role to play during an outbreak. So the first thing is to know where your expertise lies best, because like Dr. Rebu presented, during an outbreak or public health response, there are several pillars, and in all of those pillars, a lot of support is needed. There are people that are scientific officers that are working in the treatment centers as laboratory officers, and they help in sample collection, in helping us in make sure that our samples are sent to the labs, both internally and externally. So that's also a scientific officer. Of course, there are scientific officers that are working within the IPC framework. And of course, there are also scientific officers that are also part of contact tracing at the point of across the point of entries, and then also supporting the emergency operating centers. Then talking about, I didn't get the second question. Role of rural dwellers.
Yes. What can an average rural dweller do during a major outbreak?
So this is a very important question, and also very important during outbreaks. And I always like to talk about the critical importance of risk communication and community engagement. So the rural dweller, the traditional ruler, the religious ruler, and all market women and the youth leaders, these are all critical people during the outbreak. And you need to have a buy-in of everybody in the community, particularly the rural dwellers during outbreak, because if you don't have their buy-in, so many things can play out, like what we're seeing in the DRC. Perhaps the rural dweller can know that he has symptoms that look like Ebola, and he will not want to show up in the hospital. Perhaps the rural dweller can know that somebody else, his neighbor or his friend in the community, has symptoms that look like viral hemorrhagic fever, like Ebola. And that rural dweller can tell you, my friend, these symptoms you're having is something like what they are talking about that looks like Ebola. And like we have mentioned, the DRC has significant experience in Ebola Virus Disease outbreak. This is their 17th outbreak. So that rural dweller can actually help support contact tracing, breaking the transmission chain, and also support even in the safe burial. So the rural dweller and of course community engagement and risk communication is very, very critical, to sustain, to build the trust, and to break the chain in transmission during outbreaks, such as what we are witnessing in the DRC in the context of the Ebola viral disease.
All right. Thank you very much, Dr. Jesaram, for the response. Yeah, so I saw a hand raised, but it's no longer up. Yeah, so just to add that, yes, the scientific officers have a lot of roles to play. Apart from being in the lab, there are research activities that, are begging for expertise in the public health field and in emergency outbreak response. So you can leverage such opportunities, contribute to both clinical research. We just heard that there is no vaccine for the Ebola, for the Bundibugyo variety. So this is a good way to put your skills, volunteer your efforts to contribute to such endeavors. You can also do implementation research, seeing how best outbreak responses can be planned and implemented, and so on. Another question is here. I think we are out of time, but I'll just try to read so that we quickly answer that and maybe bring the webinar to a close. Kate Amechi is asking, what is the role of the Infectious Disease Center post-discharge of patients admitted in the facility? So Dr. Chizara, did you get that?
Post-discharge of care?
Yes, so I think what is the role of the Infectious Disease Treatment Center? Like after discharging patients, what other things can they do in terms of follow-up and stuff like that?
Yeah, so that's a very, 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 very important question, and I'll tell you that there's what they call the survival care program. Many times we don't look at that, but of course, the survival care program, there is post-COVID, there's long mpox, and there's also a post-Ebola syndrome. And I can tell you that the WHO is currently calling for case managers to be part of the survival care program currently, because you have 1,000 cases, you have 200 and something deaths. So it means that you have 700 and something survivors. So you need to begin to think of, and they're already thinking of survival care program. So you need to do survival care program. And what happens during the survival care program? So one, Ebola we know, can persist in the immune privileged tissues, the sanctuary sites, the central nervous system, the semen, and even the eyes. I have a colleague from the US who had post-Ebola. He had Ebola during the 2014 outbreak in DRC. He's from the US, and then had a post-Ebola that damaged his eyes, and he had to undergo survival care program, particularly with respect to his eyes, for over 1 year before he was able to recover his sight. Of course, we know that the US have better infrastructure and medications to take care of that. So that's one of it. Many of the patients post recovery can also undergo some level of psychosocial issues. So you need to continue to follow them up, bring them to the hospital, offer them psychological support. Of course, we know that Ebola can persist in the semen for up to 2 years. So you still need to continue to follow these people up, follow them up, continue to advise them on the need to practice safe sex with condoms. And also sometimes they can also have what I've mentioned as the post Ebola or post COVID or post mpox syndrome, which could be a constellation of symptoms that require some level of individual symptomatic management. So in all, you need to continue to follow them up beyond the 21-day or beyond when they test negative to PCR when they are in the treatment center, because there are many other issues and that follow post recovery.
The last question here is, there are scholarship opportunities or scholarship for staff that wish to advance their training in IPC? I don't know to who this question is directed, but yeah, I think there are a lot of opportunities out there. Just look out for them across various platforms, LinkedIn, university websites. And I think here in Nigeria, there is CCAPS. I can't remember their full name. I think it's in Lagos University. So they offer trainings in IPC. You can look them up. CCAPS is CICAPS. So
Center
hopefully
for
you will be able
Infection
to
Prevention
find.
and Control and Patient Safety in Lagos. Yeah.
Oh, great.
Professor
Great. Thank you
Ogunshola.
very much. All right. Yeah. So you can find such opportunities. And I think there's another question, but I'm afraid we are completely out of time. We have to go. What is the role of AI in IPC management? So maybe I would just add, Dr. Chizaram, do you want me to share your email address so that I can follow up on that question? If the person asking wants further response.
Okay, that's fine. That's fine. Yeah.
All right. Okay, so I'll just
Sure.
add Dr. Chizaram's email in the chat for people who would like to ask further. Apologies, we are completely out of time and we have to leave. But thanks very much to everyone. Thank you to NCDC for supporting this and for guiding the planning and implementation. We will send in our information on further episodes through our usual platforms. So please look out for our emails and social media posts on our future webinars or other panel discussions as the case may be. But for now, I think this is a good time to say bye-bye and have a good afternoon. Thank you very much. I've put the email address in the chat box for people who would like to ask further questions. Thank you very much from us, and bye-bye, everyone.
Bye. Thank you, everybody, for joining. Thank you, Dr. Kuna. Bye.
You're welcome. Bye-bye.